I think one of the most interesting things that has happened in the field of lung cancer in the last year or two has been really an explosion in in early stage disease. And for years, all of our progress was in patients with more advanced disease, and we really had old standards that didn't change for decades. And now we have a lot of new changes. Let's start with just a question of molecular marker testing. Molecular oncology changed our field 15 years ago or so, and it's continuing to evolve. It needs work, but that has mostly been restricted to advanced disease. I wanted to know what your personal practices are today. What do you think is evidence-based, and what is your personal and institutional practices for molecular marker testing for patients with resectable disease and for patients with locally advanced disease? Anybody, if you can just start with your practices. And Riyaz, if you can, I know that you know that the situation may, I don't know how much there's a countrywide policy, so you can speak to whatever you think is the prevalent patterns. But Estella, were you speaking?
No, but I will take the answer. So we did not do any reflex testing in early stage disease because there was no targeted therapy options until the Adara publication of osimertinib. And now we only do reflex testing for PD-L1, so that any patient that has surgery or a biopsy, we know the PD-L1. And then when the patient gets seen by an oncologist, the oncologist can decide what panel. But most of us do a full sequencing now on those patients that get referred. But I recently reviewed our data, and obviously we don't meet every patient that comes through the institution. So who orders a test, if it's not reflex testing, makes a big difference. But right now, I will say most of my colleagues at the University of Miami, when they meet those patients, they will order an NGS.
And Riyaz, what's your practice there?
So, I mean, that's actually a really interesting question. In the UK, we have nationally driven targets to start patients who are diagnosed as quickly as possible on systemic therapy. And we have every center treating lung cancer has a weekly, you would call it a tumor board, an MDT meeting is how we would term it. And we are very keen to reduce unnecessary waits for tests. And one of the most pragmatic decisions that many centers, certainly where I work, have made is that the pathologist, when they look under the microscope at a biopsy and diagnose lung cancer, isn't necessarily aware of the full staging of where that patient is in the pathway, right? So if they wait for that tumor board to happen and for that decision to be made and then molecular testing to be initiated, that could easily be a 1 to 2 week wait, additional delay onto the pathway. So we have a fairly straight system of reflex testing, even though I agree it's not entirely necessary for early stage lung cancer. I mean, we will basically look for PD-L1 and EGFR to be done because those are the areas, those are the two key markers that will affect early stage disease treatment patterns. But the reality is most of the patients that I treat who've had unless they've gone straight to surgery, who've had some sort of investigational biopsy in their pathway will have had quite comprehensive molecular testing routinely and reflexly.
And that's even for a stage 1 candidate.
So, well, the pathology department would not know that is a stage 1 case. So yes.